Today, Kelli Lovell of Holy Family Center for Life joins me to talk about fertility awareness. Kelli, thank you so much for taking the time to be here.
No, I'm happy to join you.
Would you start out just sharing a little bit about you and then also a little bit about your organization?
Yes. So I am a clinical pharmacist at a hospital local to me here in Evansville, Indiana. I have been there for 17 years, and my specialty is actually anticoagulation. So treating patients who have blood clotting disorders or who need treatment for blood clots or stroke, things like that. And so that actually plays interestingly into natural family planning and fertility awareness because a very common side effect of contraceptives and artificial hormones is blood clots, strokes, heart attacks. And so that wasn't something I had planned. It just is something that is. So I have been there again for 17 years. And then I am also certified to teach two different methods of natural family planning: the Creighton model of fertility care and the Marquette model. And so these are methods that allow women to track their natural signs of fertility, their biomarkers, and apply that to how they want to plan their family. And so these are scientifically proven. They have been studied using scientific model, but they aren't something that many women get access to. And so my organization, Holy Family Center for Life, was actually started 25 years ago by a woman who was using natural family planning for her own family and realized there's these great things that we have available that nobody knows about and somebody needs to teach it. And she wasn't necessarily wanting to teach it, but that's just kind of where the path went for her. Her husband encouraged her to do it. And so she started the organization, and it has continued to grow from just being Creighton model fertility care to encompassing the Marquette model of natural family planning, and also presenting just the information about natural family planning and fertility awareness to couples who are engaged or to high school students. And our goal is really to let women and couples know that there's an alternative to what modern mainstream medicine is going to tell you is the most common or the best availability to plan your family. There's definitely benefits for planning your family, but also using these natural methods to sometimes detect hormonal abnormalities or to use cooperative treatment for hormonal abnormalities instead of having to just go on a contraceptive that prevents other side effects that are not desirable.
Okay, Kelli, you have opened up so many different pathways with that. To start off with, could we talk about the efficacy of both the Creighton model and Marquette method compared with hormonal birth control?
Yeah. And so when we look at these scientific methods, so a lot of people use, so there's a lot of terms that fly around in the natural fertility world. Natural family planning is more a term that's associated with Catholicism or like a moralistic view of fertility. And then fertility awareness based models are similar, but they have a little bit different, um, I guess they often will say you can use barrier methods during the fertile time versus, an NFP says that you would not. Either way, when somebody is using a natural method to navigate their fertility, the effectiveness that they get out of it is associated with what they put into it. It's not something that you can just, oh, I learned this yesterday and I'm going to get 98% effectiveness out of it. But we have studies for these specific methods that justify using them compared to contraceptives. So let's look at, as a pharmacist, when we learn about effectiveness of drugs, there's the typical use effectiveness and there's perfect use effectiveness. So if I'm looking at an antibiotic and I want to know, perfect use is I've taken it exactly on time, the same way I'm supposed to, with or without food, without interacting medications, then I'm going to get the best effectiveness out of this antibiotic. That's perfect use. Typical use takes into account that some people will miss a dose of an antibiotic. Some people might take it with interacting medication or not take it with food. You still get effectiveness from that, just not as much as you would get from perfect use. Same thing goes for contraception. If you're using the pill to prevent pregnancy and you really need to prevent pregnancy, you're going to have a more perfect use behavior with it. You're not going to miss doses. You're going to take it on time. You're not going to take it with interacting medications. Typical use is less effective than perfect use, but you still get some effectiveness from it. And we also think of that as real world use. Nobody's perfect. Nobody's living in a lab environment where somebody's handing the pill at the right time in the right environment. And so when I talk about typical use, it's more that real world. I'm not doing it perfectly, but I'm doing the best I can. If you look at oral contraceptives across the board, the typical use effectiveness is 91% to prevent pregnancy. When you look at the scientific methods of NFP, Marquette model, Creighton model, symptothermal, the typical use average effectiveness of those is 93.3%. So that's not even using it perfectly, but following most of the rules when you use the actual method, you get more effectiveness than what you get with the pill. But if you have somebody who, hey, I need to not get pregnant and I'm going to follow the instructions, NFP becomes 99.5% effective at postponing pregnancy if you use it according to all the rules. And so there's some middle ground in there. If you're going to do typical use and not follow all the instructions, 93.3% is still the least effectiveness that you're going to expect versus 99.5% if you're really doing it. And so it is more effective than the pill at preventing pregnancy when it's used correctly. We don't compare necessarily to the IUD for typical use, because typical use with the IUD is 99.5%. But that's because once the IUD is in, it doesn't rely on you at all. It just relies on being there. So we can't beat that. I mean, you get the same with typical use as you get with perfect use with the IUD, but you're also not introducing all the major medical side effects that can come with the improper placement of an IUD or just the really scary side effects that can come with it. And so we have seen women who come to these methods from contraception and they would never go back. They will tell you that it requires more work, but they feel better. They don't have the side effects that go with it. And it allows you to make a decision on any given day about your fertility. It's not like, well, I have to go to the doctor to get my IUD removed so that we can have a baby. And again, this is all related to fertility, like using these things to postpone or achieve pregnancy. Specifically, the Creighton model, I believe, is 96% effective is their advertised rate whenever you look at that average between the methods, and Marquette is 98%. And so, like I said, 93.3% is an average, but you can get better than the average with those two methods. And those are the two that my organization teaches right now.
Okay. Thank you for going into that in more detail. I'd like to kind of circle around to this nuance between natural family planning and fertility awareness-based methods and talk a little bit more about the difference between those two. So you mentioned that natural family planning, you're practicing abstinence during your fertile window versus the fertility awareness-based methods where you're able to use a barrier method instead. And so could we just touch briefly on how using a barrier method affects those efficacy rates?
Yeah, so what's really interesting, if you think about it, is the failure rate of condoms is pretty high. So it's 18%. I think the condom effectiveness rate is 82%, and that's when you use them correctly. But that also kind of coincides with the percent of your cycle that you're infertile anyway. So women in any given cycle, so let's say a woman has a 28-day cycle, which is not common or normal. Like we say, oh, 28-day cycles, those are normal. No, women have cycles all over the place. You can have 24-day cycles. That's not abnormal. You can have 60-day cycles. Like we have to look at each individual woman. But no matter how long your cycles are, only 6 of those days can result in pregnancy if intercourse occurs and everything else is healthy. And so I think that comes out to 82% of your cycle that you're not fertile. And so the times that you're using a barrier method, if you're using an FABM, is the times that they fail the most, because the whole mechanism of the condom is that it's supposed to be preventing the seminal fluid and the cervical mucus from coming together and allowing fertilization. Well, during a woman's fertile time, that's when she has the most mucus. So if there's any seminal fluid that comes into contact with any of that cervical mucus, that's what makes condoms ineffective. And so you're kind of taking the effectiveness of the NFP method, and then if you add a barrier method, it kind of throws out everything that you knew, because you're using the barrier method at the time that it's most likely to fail. And so there's that's just from the effectiveness standpoint. There's a lot of studies that go along with the use of natural family planning and FABMs that has to do with the benefit to marriages of communication. And this is what I think my husband and I would strive the most to advertise, is when you are navigating your fertility on a daily basis, not a monthly basis, but every day, you know what your body is doing. You know if you're fertile or infertile, given what your body is telling you through tracking these biomarkers. It changes the way that you're able to communicate on every level. I mean, your fertility and your intimacy is so personal and so intimate. I mean, intimacy is intimate. It's so personal that if you can talk about that, then you can talk about finances probably without fighting. You have discussed what is our reasoning behind being open to having a baby right now and not being open. You have to discuss your fears, your concerns, your hopes, and you do that on a regular basis when you're using a natural method. And so I think that sometimes adding in a barrier method during those times kind of undoes some of that openness and willingness to be totally giving of yourself to the other. And so it's just, I think that if I gave you all the testimonies of all my clients who have gone from contraception to natural family planning, they would tell you, it's not easy. It's not like it's the easiest, way to go, but it's so rewarding because of that communication, and it has improved their marriages even when they thought their marriage was just fine. They were like, we thought things were great, and then we started using this and we were like, oh my gosh, things are even better. So it's been beneficial even just for my clients when they tell me about their experiences.
Thank you so much for sharing that. To kind of highlight another thing that you've already brought up is this idea of using fertility awareness or any of these natural family planning methods for hormonal imbalances and to recognize those hormonal imbalances. So let's go down that path for a little while.
Yeah. So I think one of the best examples is my husband and I were open to having a lot of children. We wanted a big family. I came from a family with 7 children. He came from a family of 4 children. And it actually took us a long time to conceive our first, which was very surprising to us because my cycles were absolutely normal. There was nothing, I mean, I was practicing NFP. I knew my cycles were normal and we were not achieving pregnancy, which is, anybody can tell you when you're ready to get pregnant and it's not happening in the first couple of cycles, it's very emotional. So we did finally achieve pregnancy with my first son, and then our second one came pretty quickly behind that. And we were like, okay, whatever it was, we've overcome it. And then we had a miscarriage. And those are very common. And unfortunately, we as women sometimes are very um, quiet about it until somebody else goes through one. And that person is like, how come nobody ever told me? I felt so alone. So I went ahead and went to there was a presentation about Creighton model. So I had not been doing Creighton model myself up until this point. And as I'm sitting in that presentation, they're talking about tendencies in a cycle that can show signs of increased risk of miscarriage. And one of those is low progesterone. And the simple fix to that is giving progesterone supplementation in the early phase of pregnancy to support the embryo as it's growing and before the placenta takes over. So I'm looking at what I know about my cycles and I'm thinking, oh my gosh, I have one of those markers. The time between my ovulation and the time to my next period is too short. And so with that pregnancy, I took progesterone and I did not miscarry. And since then, I have not miscarried any babies when I was on progesterone support. And so women who have this information about their cycles, even if it's just the very basic, like this is how long my cycles are, this is how variable they are in length, this is, we've detected ovulation using whatever biomarker and can count the number of days between ovulation and the period, we can tell if they have decent progesterone production. We can tell if their PMS is problematic because of low progesterone. A lot of women with problematic PMS, it's related to low progesterone, and we can see signs of that in their chart. But we also can say, gosh, your chart makes me suspicious of PCOS. And we can go ahead and have them evaluated for that and navigate that. And when we have a lot of women with infertility, we will look at their risk of endometriosis based on their cycles. And so we are expediting the road to treatment by looking at our cycles and detecting abnormalities before they even cause problems. For example, I can have a couple who is charting before marriage, they're practicing abstinence, and I can say, gosh, your progesterone might be low. We need to get it checked because if you would achieve pregnancy, you would be at a higher risk of miscarriage. And they can have that knowledge going into it versus waiting until they've lost 2 or 3 pregnancies before they get treatment. It helps us to kind of help women as they navigate towards menopause and to know what their symptoms are showing, what stage of menopause they might be in, so that they know when and if they should continue to chart their cycles. There's what we call it is cooperative treatment of the cycle. We're not going to give you the band-aid of a contraceptive pill that just gives you estrogen every day or gives you some progesterone. We're going to treat what's wrong and we're going to fix it with what you're missing. Treat it as a disease instead of just giving you a band-aid that if you ever stop taking the pill, it's just going to come back and then you're in the same boat. Only this time you might be trying to get pregnant rather than prevent pregnancy. So it really puts the power of a woman's fertility in her own hands because she knows so much about her fertility and her hormones before she's ever in that stage of life that it's devastating when several cycles go by and you haven't achieved pregnancy.
Yeah. So a quick question about the progesterone supplements that you were taking. Is this natural progesterone?
So what I took was just a prescription Prometrium product. And so there's lots of different ways people take it. Usually, if a woman is in a pregnancy and been diagnosed with low progesterone, she might be fine taking that oral progesterone. But if her numbers aren't coming up and reflecting that, we can do injections, like intramuscular injections of progesterone. We can do vaginal suppositories, but there's bioidentical progesterone products that we can use. And I think those are what Creighton model is so focused on. Like, we want to give you something that's bioidentical and not steroid based and going to present other side effects because it's on that steroid molecule.
Okay. This kind of leads into, and actually a few of the things that you just mentioned in that kind of lead into this, the Creighton model being so heavily focused with um, the NAPRO, or the natural procreative technologies.
Mm-hmm.
Is Could we maybe launch off into that for just a minute? You mentioned treatment for endometriosis,
Oh, yeah.
um, just regulating helping to regulate the cycle and giving these bioidentical steroids, or sorry, bioidentical hormones at the appropriate time during the cycle.
Yes.
So,
Yes. Um, yeah. So Dr. Thomas Hilgers is the mastermind of Creighton. It started out kind of piggybacking on the Billings ovulation method, but then he took it a step further as he was in medical school and said, we can treat women with this cooperative medicine approach, but nobody wants to do it because it's hard and it's not proprietary. Like, we're not selling any brand name drugs that get made by a big name company. And so he pursued it and made it what it is today. But NAPRO is the medical arm of the Creighton model. So anybody who enters the Creighton model system learns how to chart using cervical mucus only. But your cervical mucus, which is critical to achieve pregnancy, is going to tell you a lot of things about your estrogen and about when you're post-ovulatory and what your progesterone is doing. And so your instructor, who's not necessarily a physician, is trained to teach you to chart, look at that chart and say, gosh, you have biomarkers for low progesterone, or you have biomarkers for PCOS, or all of these things. We do not diagnose it. We refer you to someone who can diagnose it. So that's a big caveat. I'm not telling you I can diagnose you with anything, but I can tell you, hey, there's reason to suspect that you have this issue. Let's get it diagnosed and treated now. So the second part of Creighton is NAPRO, and that is a group of physicians and surgeons who have embraced this natural reproductive approach, and the only procedures that they will use to help with fertility or hormone imbalance or reproductive illness is the natural approach. They will not prescribe oral contraceptives, which there are places in medicine where even the Catholic Church doesn't say you cannot take the oral contraceptives for acne, or you can't take it for PMDD or anything like that. But there's a better alternative. We can give you something that's better than that if you're willing to look for it. And so that's what these doctors do. They say, let's figure out what your estrogen is doing. Let's run some labs, figure out what your progesterone is doing, and then we're going to treat that. One of the biggest benefits that comes from NAPRO is the approach to infertility. And so if we have a woman in just the regular track of modern medicine who is infertile, so we're going to say infertile. Modern medicine says infertility is 12 months of trying to get pregnant and it doesn't happen, just using random acts of intercourse. With charting a natural family planning method or a fertility awareness based method, we can be pretty certain about your ovulation, your hormones, what they're doing. And so we really only need 6 months of charting before we would say, something's going on. You're using it correctly and not getting pregnant. Let's fast track you to somebody who can help you. These NAPRO doctors, some of them are just family practice. I don't want to say just family practice, but sometimes it's a family practice physician who can run the labs or prescribe the hormones. And sometimes it's an OBGYN who's done a fellowship in surgery through NAPRO technology, and they're not going to do an ultrasound and say, oh yeah, it looks like you probably have endometriosis. They will go in, diagnose even microscopic endometriosis, and treat it right there and restore a woman's fertility. So a lot of times when modern medicine is sending women straight to an IVF clinic and doing artificial reproductive technologies, they don't have knowledge that this NAPRO technology approach is available, way cheaper than IVF, but also it's potentially restoring their fertility so that they can have multiple children after one procedure rather than have to wait and redo IVF every single time.
Okay. And just briefly, what is endometriosis for anybody who's listening and not know what it is?
So, endometriosis is actually one of the most common causes of infertility. And it's when, for whatever reason, the endometrial tissue that is supposed to line a woman's uterus between cycles, that endometrium builds up and then it's sloughed off when we have a period, that tissue potentially can migrate out into the abdominal cavity and grow all kinds of other places. This is not normal. I mean, this is an illness, and it can grow on the bowel, it can grow on other organs, and it usually causes really painful periods, a lot of cramps, because that tissue, even though it's outside of the uterus, is responding to the same hormones that your uterus does. So we used to think, oh, well, then those people would probably have, certain symptoms, really heavy periods, or, you would tell it from their periods. There are women who can have no symptoms and they have infertility, and these doctors go in and they find endometrial tissue all over their abdomen. And there's such a thing as microscopic endometriosis, where they're just these tiny pockets that are affecting fertility because they are exerting hormones just like the endometrium is supposed to. And that's what's causing infertility. So when these doctors go in and enter the abdomen, they automatically go in and just remove all of that microscopic endometriosis. And generally, I'm just spitballing this, but I believe once you've ablated that endometrial material, it restores fertility for 3 to 5 years. And so during that time, if women achieve pregnancy, generally the process of pregnancy and sometimes breastfeeding slows down the return of that endometriosis so that they're able to maintain that level of fertility for a while before they may have to do the procedure again if they want to have more children. It's all very dependent on each individual person. But yeah, so many times the cause of infertility is endometriosis, and to have a doctor say, well, you don't have painful periods, so it's probably not that, is not an accurate statement.
For this, the NAPRO practitioner would be doing a laparoscopic view inside the abdomen and finding
Yes.
these pockets.
Yeah,
Okay.
yeah. I mean, it's major surgery. I mean, they go in and they don't do it lightly. It's not like you call and ask for referral and they're
Yeah.
like, "Well, let's get you scheduled for surgery." You're going to have a
Yeah.
consult. They're going to work up everything. They want to see these charts. So even if, if somebody listening to this is like, "I've been struggling with infertility, maybe I have endometriosis. I want to go to one of these doctors." They're going to want to have several cycles charted so that they have that to go off of, because they don't want to take you straight to surgery if there's something else. But they need to see, okay, intercourse is occurring at the right time to achieve pregnancy and you're still not pregnant. What are our next steps to determine if endometriosis is something? Because they're not going to take you to surgery if there's not reason to do so. But
Right.
there's tons of really great NAPRO doctors who are doing these procedures, and there's pockets of them. Like in St. Louis, there's a really large NAPRO practice concentration, I will say. And then, of course, in Omaha, Nebraska, that's where the Institute for Creighton is. And so Dr. Hildress is there, and there's a lot of availability. And women will go from all over to go to Omaha to see Dr. Hildress or the people that practice with him. But they're all over. I mean, there's one, I'm in Indiana, and there's one in South Bend who's amazing. And I think they're working on training one who's going to be in Indianapolis. I mean, they're all over. You just have to know where to look.
Um, Maybe kind of final question on endometriosis. So, um, does it necessarily have to be endometrial tissue on either one of the ovary, either one or both of the ovaries, or it can just be somewhere else and still
No,
contributing to
it can
infertility?
be anywhere. It can be anywhere
Okay.
and contribute because again, it wherever that tissue is, it's exerting the effects of the hormones that would normally be, you know, focused
Local.
in the uterus, but now it's all over the place. And so yeah, it does not have to be on the ovaries, although sometimes it can be. Um, but it, yeah, usually women are told, well, you should be having really painful periods. But I have plenty of clients who that's not been the case for them, and that was the cause of their infertility.
Okay. And I think the other thing about, because it's way beyond endometriosis and even beyond PCOS with the Creighton model and NAPRO, because they've gone so far in and even subdivided that luteal phase deficiency that you were talking about, where it's too short
Mm-hmm.
of a time period between the time you ovulate and the time that you start your period, into subcategories based on kind of how it presents in your cycle,
Yeah,
which is, it's fascinating what has gone into the Creighton model.
I love either method when I'm teaching clients. Um, Generally, when they start to see just after one or two cycles what their body is telling them,
Yeah.
almost always the response is, why didn't anybody tell me this before? Even
Yeah.
if you're going to go down a different track with how you plan your family, young women, once they hit puberty and start into their cycles, should have access to this information. Like, we deserve access to this information because this is how our bodies work. We were not created to get pregnant every single day of our lives. There is a very natural cycle of when we can achieve pregnancy. It's God made us this amazing way that we don't have to get pregnant every time we want to be intimate. Um, but we have to have the ability, the patience, the willingness to put the time in to understand it. But once you see it, you can't unsee it. It's like, oh my gosh, my body is telling me all these things, and I don't have to be depressed or anxious or have all of these side effects from these artificial hormones. Um, because yeah, I mean, I have lots and lots of testimonies that we pass out locally when we do presentations of couples that speak to, why didn't I know this sooner?
Um, Kelly, there's kind of three different paths to take this here. What you just said, your activism is starting to show, and I think I'd kind of like to.
Oh, well, that's dangerous.
Okay, well we can skip it. Yeah,
No,
it's totally up to
I can
you.
talk about whatever you want to talk about. You can see I'm passionate about this. Um, it was a gift to me that I was brought up in a family that, obviously there were seven of us. Like, my parents were very open to life. There is no prerequisite. So I am convicted of this because of my Catholic faith. It's not a Catholic teaching. It's a Christian morality we can all get on board with if you're Christian. Um, but for me, I knew that contraception wasn't something that was good for me, and so it wasn't something that I was even considering. But the level that I'm involved in it now is not anything I would have anticipated, because I just was trying to plan my family, going through what infertility looks like. I mean, it wasn't infertility, but those first 2.5 years we were trying to get pregnant, what that looks like when you're not having hormonal irregularities. And so that gave me a heart for these women who are not being told how their bodies work, and who are not being told there's something out there that you can understand yourself and that your spouse can understand you. Because as soon as I have two daughters right now, as soon as they are in that period of their life where they're starting to have cycles, they're going to be introduced to this at an age appropriate level. They already are at 3. My 3-year old probably has no idea, but my 9-year old knows there's a monitor that sits on the counter in our bathroom, and that monitor I use on a regular basis to know if my body can have a baby right now or not. She doesn't know any more to that, but when she gets to the point where she's cycling, she's going to know this is what your body can tell you, and I'm going to empower her with that. It's so what no matter what you do it for. If you do it because it's natural, if you do it because you had a bad reaction to some sort of contraception, if you do it for religious reasons, it's still legit. It's still the same effectiveness. It's still scientifically valid. There's nothing about it that somebody can say, oh, that's not a thing. Those people are making it up. No, we're not making it up. But it's not something that you're going to encounter on a regular basis because it's not popular. It's not mainstream. There's no advertisements, which nobody watches advertisements anymore anyway. But yes, I am very passionate about it because I want what it has done for me to be available across the board. And I'm not judging anyone who may be using contraception or doing IVF. Everybody has their own road, their own decisions to make. But I want them to know that this is out there. If they want something different, this is not what you're going to encounter mainstream, but it's the worst kept secret. It's the worst kept secret.
Okay, so you mentioned this monitor, and we
Mm-hmm.
haven't yet talked. We've spent quite a bit of time here talking about the Creighton model. Um, let's talk about so you started off as a Creighton model instructor, and then what was your progression to beginning to teach Marquette method
Marquette.
as well?
Yeah. So um I was trained to teach Creighton in 2015 and was Creighton worked great for me. It works during breastfeeding, it works all whatever situation you are in your life. Creighton is applicable. But um I was teaching women Creighton and I would have all these other women come up to me and say, "What do you know about Marquette?" I'm like, "Why would you need Marquette? I can teach you Creighton." And they're like, "Well, I did Creighton and it didn't work for me." And I thought, it's 96.6% effective. What do you mean it didn't work for you? Well, sometimes not every method of NFP or the FABMs is a good fit for everyone. Some women have mucus all the time, and that would make it difficult to navigate Creighton. You can, but it makes it a lot more difficult and intensive. And so I thought, well, I teach Creighton. I don't need to teach something else because I'm still a pharmacist. I have all these kids, and I don't need to mix and match methods and get confused. But to teach Marquette, you are required to have a medical degree. And so it can be a physician, a pharmacist, a nurse, a physical therapist, occupational therapist, some sort of medical degree, but it's very heavily nurses. A lot of nurses do it, which is great because they have the training and they have that teaching ability. So I thought, I'm just going to ask all of the medical professionals I know. I work at a hospital, I know a lot of them, and see if somebody else wants to do it. Well, everybody thought, well, that sounds great, but I don't have time for that. I don't want to do it. And I thought, but it's needed. Like, if women want to use a natural method, not every method is good for every single woman. I want them to have access. So fine, I'll do it. So I went through training for Marquette and finished that. I started it, I think, in 2019. I just finished the certification phase. So I passed my certification exam this past February. And what Marquette does is it allows women to have objective information about their hormones. And so in general, Marquette is based on the use of a urine hormone monitor, usually a monitor that is designed for women who are trying to get pregnant, although there's newer monitors coming to market that do even more than that. And Marquette is going where the science is going. So if a new monitor that's more sophisticated comes to market, they're assessing it. They're looking at how can we apply this going forward. And so that's really refreshing in the NFP world when people still think that all we have is the calendar rhythm method, to be able to be like, no, we actually use these really fancy monitors to be very certain about your hormones. Marquette teaches women when to test their urine throughout the cycle And then whichever monitor they use or whatever testing they use helps them determine when ovulation is approaching and when ovulation has passed so that they can be fairly confident about the end of their fertility. So I feel like if anybody wants to teach a method, they should use the method. So I couldn't be like, yeah, I teach Creighton and I use Creighton, but I also teach Marquette, but I don't use it. So I just started charting Marquette as well. And there were things about Marquette that were more accurate for me than my mucus was. And so even my husband was like, this is better. Not better from a more accurate or, I don't want to say better. My own
Easier.
perception was what Creighton would tell me was still fertile, Marquette would tell me fertility had passed. And when you're
Okay.
comparing the two, when you're comparing the accuracy of mucus to the accuracy of urine hormones, just scientifically, your urine hormone information is more accurate about detecting ovulation than what mucus is if you have mucus all the time. So there's some women who will have very specific mucus patterns that their time frame of abstinence to observe fertility is fairly short. But if a woman doesn't have that very definitive, here's where I have mucus, here I don't, the urine hormones can clear that right up. I mean, if you have a urine hormone monitor and it says, oh, here's your LH surge, we know how soon ovulation follows an LH surge. We know how long you could possibly be fertile after an LH surge so that you can say, okay, this point forward, I cannot achieve pregnancy. Now, these are all caveats to you need to understand the method from a certified instructor and not take this statement as this is how Marquette works. But it is that accurate. It is, if you can identify the LH surge, you know how to determine the end of fertility for that cycle.
Um, just one more question. I kind of want to switch gears, but I have one more question kind of around this with the Marquette, because you mentioned earlier on 98% efficacy with perfect use for this one. Are they finding greater efficacy with the newer monitors?
They haven't studied it. So
Okay.
the reality about Marquette is you need time to really get accurate on the fertile window. Fertile window being the time that you observe abstinence if you're trying to postpone pregnancy. We still depend on an algorithm in addition to the monitor because there is variability in the pre-ovulatory phase of the cycle. That's what gives it the 98% effectiveness, because it does have a very conservative start of fertility when you first start charting. The only reason we don't know with these monitors is because they have not been scientifically validated with Marquette. So these monitors are quantitative, where they give you your concentration, a numeric concentration of estrogen, a numeric concentration of LH every time you test. You don't get that with the monitor that Marquette was initially based on. And so once these studies with the newer monitors get done, they will be able to give you the breakpoints to maintain that 98% effectiveness. But they don't have the studies completed yet to correlate it and say, yeah, just switch over to this monitor. It's going to give you 98% effectiveness too. Because they need to figure out what the breakpoints are for the quantitative readouts.
Yeah, I was actually thinking a little bit in reverse and thinking more about the qualitative monitor that Marquette started with, and just about, whatever algorithm it's using to give you that low high reading. If
Mm-hmm.
there may be some women who just have lower estrogen in general, so it doesn't register, it doesn't trigger it as being a
Yeah.
high day.
Yeah.
Um, I think that's
I think that the most useful place that it's going to apply is breastfeeding too,
okay.
because your estrogen should follow a bell curve when you're in regular cycles. So it continually rises as you approach ovulation and it peaks and drops before you ovulate. When you're breastfeeding, your estrogen doesn't follow that. Every time the baby nurses, it kind of stalls out and it's more of a plateau effect. So the qualitative monitor can't navigate that. It's not made to
Okay.
navigate that. That's not what it was made for. We're kind of using it in reverse. With these newer monitors that are quantitative, you'll be able to see. You'll be able to see that rise and drop in estrogen. And so even if you have a woman who has low estrogen at baseline, she'll be able to have a feeling for what the trend is. And that trend itself is what's going to make it more applicable because we can see the change from one day to the next. The qualitative monitor depends on a percent increase over 3 days to register a high. And so it's going to be applicable once we figure out how to correlate the numbers versus the qualitative readouts.
Okay. All right. I said that was the last question. I'm just kidding. Because when you're just talking about the algorithm for the qualitative monitor, now that has me wondering, does Marquette University, have they worked pretty closely with CBFM to know what
Yeah.
that algorithm is so
Yes.
that they, okay.
Yeah. So we have, I say we, Marquette has people who kind of become default experts. So like somebody before I ever was involved in it was like, I'm going to talk to a rep from CBFM and have them tell me more about how the monitor works. So I was fully trained in Marquette, and then I watched this webinar by this expert, the instructor who became the expert. And I was like, oh my gosh, this, now that I know how the monitor works, like it totally changed the way that I practice and the way I teach my clients. Because if you understand how that monitor works, there's so much more that you can get out of just everyday reading. There is a default person with the newer monitor that she's now presenting a webinar that's, I've worked with a Mira rep. I just said Mira. I work with a Mira rep, and they are teaching her how that monitor works and all the different things that we need to know as teachers to help women navigate that monitor. So yes, Mira is working very closely with Marquette to help them really break down the science and make it more accurate and more usable. Clear Blue, I believe, has done the same. I mean, they have somebody who they talk to who tells them, how things are going. And so, yeah, these companies, to my knowledge, are at least somewhat helpful to let us, use the technology that wasn't necessarily designed for this, but is being used in this way and helping us navigate that.
Okay. Thank you for indulging me on that one.
Yeah, that's okay. Yeah, no problem.
I wanted to circle back around to what you're doing as a pharmacist and kind of this area of working with people with blood clots.
Yeah.
Uh,
So
yeah.
when I started as a pharmacist 17 years ago, I went into hospital pharmacy kind of with no idea where I was going. It was a time when there was a major shortage of pharmacists, and most new grads would go to retail pharmacy because it paid better. Um, I didn't know what I wanted to do, but Purdue University always told us if you think you want to do hospital pharmacy, you should do it right out of school because that knowledge base, if you don't use it, you'll lose it. So I thought, well, I might as well try for hospital. And if it doesn't go well, I can, go to retail. So I was the only pharmacist they hired that year. And I told them in my interview, I don't know what I should know as a hospital pharmacist because I didn't have great experiential rotations at the hospital I was at. But if you will teach me, I will give you 110%. And so this great group of pharmacists like heavily trained me in hospital pharmacy and made me um, a much better pharmacist than I was on day one. But as a new pharmacist who doesn't really have a specific direction, some pharmacists know I want to do critical care, I want to do neonatal medicine, things like that. I just wanted to be a pharmacist and be good at what I did. So one of the pharmacists said they had an opening in our anticoagulation clinic and they thought I would be a good fit because this is an outpatient clinic where you're face to face with the person and you're helping dose their anticoagulant, which in most cases at that time was warfarin. And so I was like, well, I want to be useful, so sure, I'll do that. So I had no intention of getting involved with anticoagulation as a passion, but just to fill a need. And so I got involved with that. And when you do, our clinic required you to be certified in that so that they could say all of our providers are certified. We have special knowledge, which is totally appropriate because that's a whole different set of medicine, a whole different set of practice. And so I took that test, I passed it. And as I was getting more established in that practice, I was helping to write the protocols of treatment and to learn more in depth about what we're doing. And I'm seeing all these young women who are coming in with blood clots. And I don't want to say it's like 75% of the population. No, that's our elderly patients with heart arrhythmias. But there's definitely women coming in who went to the gym to work out one day and got short of breath, went to the hospital and had a blood clot through both of their lungs. And when you look at what could cause this, there's very definite things that put you at risk for a blood clot. When you are less than 35 and you're active and don't have other risk factors, the first thing we look for is artificial contraception because the estrogen that's in those medications disrupts that clotting process and puts you at risk for blood clots. And blood clots are life-threatening. I mean, when we're lucky, we catch them before they become life-threatening. But that was before I was teaching NFP. And I just remember thinking, man, I'm glad I don't take those. Like if I needed a reason not to be on contraception, that would have been enough. Not just because I practice NFP, but seeing these women come in with blood clots, I didn't want that when I could do something else. Which I think is why a lot of women will switch to IUDs and things like that because they don't have that same blood clotting risk, but the other side effects they carry are scary too. So, there's not a perfect way to do this. So that really made me appreciate the NFP side of things right along with that. And I found myself with these women in my office and I'm thinking, well, now that you've had a blood clot, you can never take hormonal contraceptives again. It's an absolute contraindication. But I kind of want to tell you about NFP. And I would, and usually get laughed out of the room because they're like, no, I'm not doing that. But I kind of thought, well, this is my opportunity to at least put that idea out there. Yeah. And there's a line that I have to tread. Like I don't know legally what that line is, but I try not to mix the two. Like I don't want to refer directly to my natural family practice from the hospital I work for, but I can give that information because it's public information. But I'm working a lot to try to get my hospital to introduce coverage for NFP services for their employees, to make it easily findable for women when they go to their OBGYN office to have that. And it's not an easy thing to do. I think the perception is nobody does this. And the reality is lots of people do it and they just have to wing it because nobody's giving them the resources at an actual medical office. And when we try to find doctors for women who say, I want somebody who understands NFP, I want somebody who understands what my chart means, but I don't live in St. Louis, I don't live in Omaha, Nebraska, it's kind of a desert. I mean, there's just not doctors in my hospital that I know of that can look at an NFP chart and say, I know exactly what you're talking about. I can look at this and interpret it. And that's pretty discouraging because it's legit medical science that's just thrown by the wayside because it's not going to get anybody a lot of money. I don't make significant money doing this. I get paid way more to be a pharmacist than I get paid to do this, but that's not why I do it. I do it because somebody's got to do it, and I've put the time in, and I'm going to keep doing it until somebody tells me to stop, and then I'll probably still do it. So,
Kelli, thank you so much for your time. This has been such a great conversation. As we wrap up, how can people connect with you?
so the best way to find information about us is our new website, and it is the easiest way is hfcl.org. So Holy Family Center for Life.org. You can type in the whole thing, Holy Family Center for Life, but that's a .com. Right now, we're so new that if you try to Google something, you may not find us. So hfcl.org is the best way to find more information. Our website lets you automatically enroll in our services. If you want to go to, the first step is to do an introductory session where we teach you about the method, and then you can decide whether you want to enroll. But there's also a lot of basic information about Marquette and basic information about Creighton and what we are doing locally to try to improve access to these services. But we teach virtually all across the US. So I have clients who live in Wyoming, Colorado Springs, all over, because there are not instructors everywhere. And so no matter where you are, we will teach you. I'm the only Marquette instructor at my organization, but we have 5 active Creighton practitioners. So usually I focus on my Marquette clients and get the Creighton clients over, but I do still teach Creighton if people request me. And so going to our website, you'll find tons of information, and you can contact us if you have any specific questions. There's a contact us page, and you can go right to that and put in some info, and we'll get right back to you.
Okay. Thank you so much, Kelli.
You're welcome, Brandy. Thank you for having me.